today's topic of discussion. This is molar pregnancy. Now, what do you understand by molar pregnancy? Molar pregnancy is not a normal pregnancy. It is a tuberous growth of the cytotrophoblast and syncytial trophoblast. So, which leads to different types of uh, trophoblastic diseases. The most common is vesicular mole or hydatidform mole. It may be complete or partial. Second is invasive mole, which is non-metastatic. Third is a metastatic uh, choriocarcinoma. And fourth is placental cytotrophoblastic tumor. So this is how you classify the trophoblastic diseases. Now we will discuss first of all vesicular mole or hydatidform mole. It's a benign condition, benign neoplasm of the chorionic villi, which is characterized by hyperplasia of the trophoblastic cells. As you can see over here, there is hyperplasia of the trophoblastic cells. Hypertrophic swelling of all the villi. This is the hypertrophic swelling of all the villi. And absent vascularity. And there is no vessels. So there are three characteristics: hyperplasia of the trophoblastic cells, hypertrophic swelling, like grape-like structures, vesicles, and there is absent vascularity. So this is a histopathological slide showing vesicular mole, and this is normal villi. As you can see over here, there is hypertrophic swelling of the villi, absent vessels, no vasculature, and there is hyperplasia of the trophoblastic cells. It occurs in 1 in 2,000 pregnancies in the United States and Europe, and 10 times more in Asia. So predisposing factors include it is race, deficiency of protein or carotene. The incidence is high toward the extreme of childbearing age. It is more common in young age and in the old age. So 10 times more in women over 45 years of age. So it is age related also. Regarding its pathology, the uterus is distended by thin-walled, translucent grape-like vesicles of different sizes, just like grapes. When you will see on naked eye, if a patient is passing these vesicles, they are just like grape-like structures. These are degenerated chorionic villi filled with fluid, and there is no vasculature in these villi, and it leads to early death of the embryo. So there is no embryo in case of complete mole. So these hypertrophic changes, this lead to excessive production of this hyperplasia of the villi, leads to excessive production of beta HCG, and this excessive beta HCG, what it will lead to? It will lead to excessive vomiting, and it will lead to it will have its effects on the both ovaries, which will lead to multiple thecal lutein cysts in about 50% of cases, and sometimes these cysts may be as large as 10 centimeter or more. This is a picture. This is the ovary, and you can see these are the cystic changes in the ovary. So these are thecal lutein cysts. This is one ovary and this is other ovary. These are the thecal lutein cysts. These are the cysts in the ovaries. This is under the effect of excessive beta HCG. So this is disappears after the treatment of the mole, and within it takes about 2 to 3 months. Now, molar pregnancy may be complete mole or incomplete mole. In complete mole, there is no fetus, while in incomplete mole, there is a fetus along with hydropic swelling of the villi. So, the incomplete mole whole conceptus is transformed into a mass of vesicles, no embryo. It is the result of fertilization of enucleated mole. An empty egg, which has no chromosomes, with a sperm which will duplicate, giving rise to 46 chromosomes of paternal origin only. As you can see over here, this is an empty egg. It is fertilized by a sperm, which leads to content chromosomal content 46XX. This is only from the paternal side. No contribution of chromosomes from maternal side. And this will undergo division and it will lead to 246 axes. These are the vesicles. This is how you will see grape-like structures when you will do evacuation of a such patient. Like this. These are the grape-like vesicles. Hydropic swelling of the villi containing fluid. There is no vessels, no baby, so this is a complete mole. No partial. It has a part of trophoblastic tissue which shows minor changes. There is fetus or at least an amniotic sac. It is the result of an ovum by two sperms. So the chromosomal number is 69 chromosomes. This is a partial mole. You can see the baby fetus along with the placenta and vesicular changes, hydropic swelling. So this is karyotyping of a partial mole. This egg, 23 eggs, is fertilized by two sperms. And what happens? There will be trisomy, 23 eggs, 23 eggs, and 23 Y, which leads to total chromosomal complement 69 XXY. So it contains both maternal and paternal contribution. So 69 XXY or 69 XXY. So how we can differentiate between a complete and partial mole? In the complete mole, there is no fetus. There is a diffuse swelling of the villi and trophoblastic hyperplasia is also diffuse, and karyotyping is paternal contribution only, that is 46XXY or 46XY. While in partial mole, there is no embryo, there is focal swelling of the villi and trophoblastic hyperplasia, and the chromosomal content is 69 XXY or 69 XYY. Malignant change is 5 to 10% in complete moles. In complete mole, we have malignant change, while in partial mole, it is very rare. So, how we can diagnose a molar pregnancy? It can be due to silent symptoms. The symptoms include there will be history of amenorrhea, usually short period, 2 to 3 months. There will be exaggerated symptoms of pregnancy, especially vomiting, excessive vomiting, and she may develop signs and symptoms of preeclampsia, as she will have headache and edema. There will be vaginal bleeding. This is due to the separation of vesicles from uterine wall, and these vesicles they are passed to the vagina along with the blood. Prune juice discharge may also occur, and this passage of vesicles, grape-like vesicles, is diagnostic. Whenever you see passage of grape-like vesicles vaginally, you must have a suspicion that it is a molar pregnancy. The blood may be concealed, causing enlargement or tenderness of the uterus. Sometimes there is no external bleeding, and there is uterine enlargement and tenderness. She may also have pain, dull ache, colicky or sudden and severe due to perforating mole. Sometimes it is a very severe pain due to the perforation of the mole into the uterine wall. There will be also abdominal pain due to the stretching of the ovarian capsule and complication in the cystic ovary as well. Sometimes these ovaries may undergo torsion, which will lead to acute pain, abdominal pain. What are the signs? So when we will examine the patient, we will see the signs and symptoms of preeclampsia, that she will have headache, she will have edema, and if preeclampsia develops before 20 weeks of gestation, then we must think of molar pregnancy. She will be having pallor due to the anemia, hyperthyroidism in 3 to 10% of cases, as the uh, beta subunit of HCG resembles the beta subunit of TSH, so there will be hyperthyroidism also. So, breast signs of pregnancy, there will be more tenderness of the breast and when we examine abdomen, we can find uterus is larger than the gestational age. We find the uterus is larger than the actual duration of pregnancy, and it is doughy in consistency. It is soft due to the absence of the amniotic fluid and its distension with vesicles. The fetal parts and heart sounds cannot be detected except in partial mole. So if it is complete mole, we can feel the fetal parts or can hear the fetal heart sounds. So when we examine vaginally, there will be passage of the vesicles, there will be passage of the blood along with the vesicles, there will be on biobanal examination, both of these are enlarged, and there is no internal belonging. So what investigations we will do? First of all, we will do serum CT, which is elevated, usually it is more than 1 lakh. And ultrasonography shows snowstorm appearance with no fetus. And X-ray of the chest should be performed in cases if we are suspecting metastasis or trophoblastic tumor. This is partial mode. These are cystic tumors. So, partial mode, there is a fetus, and hydrophyte as well, some of the placental tissue. This is complete mode. This is uterus, and this is the uterine cavity, which is filled with plate-like vesicles. There is no fetus. Here you can see these vesicles. These are these black circles. They are the vesicles. So this is like snowstorm appearance due to non-cystic areas. So this is characteristic of this picture. It's characteristic of complete mole. This is real-time ultrasound of a molar pregnancy. It's the natural history. The complete mole after molar evacuation. Local uterine infection may occur in 50% of cases and metastasis in 4% of cases. High risk factors for post-molar tumor or metastasis when beta HCG level is more than 1 lakh. Excessive uterine enlargement. Thicker uterus is up 6 centimeter in diameter, and older patients they are also at increased risk. In case of partial mole, the persistent tumor usually is non-metastatic. It develops in 2 to 4% of cases. Chemotherapy is required to treat the issue. So, whenever there is a molar pregnancy, there are sub-complications which may occur. First of all, excessive hemorrhage. Diffuse hemorrhage. Patient may present with excessive bleeding or infection or perforation of the uterine wall due to the invasion of the molar tissue into the uterine cavity. Or hyperthyroidism and sinus symptoms of preeclampsia. She may have early preeclampsia before 28-60 station, and she will also the patient will have develop the hyperthyroidism. In about 5% of cases, there is invasive mole, metastatic tumor that is called carcinoma, and invasive mole which is non-metastatic in about 10% of cases. Recurrence may occur in about 1 to 2% of cases. So complications are hemorrhage, infection, perforation, uterine wall, preeclampsia before 20 weeks, gestation, hyperthyroidism, choriocarcinoma in 5% of cases, or invasive mole in 10% of cases, and recurrence may occur in about 2% of cases. So how we can treat molar pregnancy? The gold standard for the treatment of molar pregnancy is section evacuation. This is the gold standard. Not curettage, only suction evacuation. So whenever we are going to do suction evacuation, we start freehand 20 units of oxytocin in 500 ml of 5% glucose or indirectly, which is started IV before the start of the evacuation and continue for several hours to enhance system contractility. If the cervix is not dilated, then we have to dilate the cervix. That is dilated. If the uterus is 10 weeks size, then we will dilate it to 10 weeks. Head is 10 centimeters or size 10 of head. And these are the hepatitis and dilators. They are of various sizes. And both ends they have different sizes. If this is 4, this will be 5. If this is 6, then this will be 8. So they have different sizes on both sides. So suction cannula will be used of the same size also. This is suction cannula. So what we will do, we will attach from here to the suction machine, and after dilatation of the cervix, we will introduce to the uterine cavity, and with in and out movement, we will start evacuating the uterine cavity. Once you start evacuating the uterine cavity, what will happen? These vesicles they will come out, and these vesicles they will come out, and what will happen? The size of the uterus it will start decreasing at the same time. So these villi which are removed from the uterine cavity, they are sent for histopathy for histopathy to exclude malignancy. These are the villi with hydrophobes value which are sent for histopathy. After evacuation, uh, you can gently cure it, the uterine cavity with a sharp cure. Do not use force, otherwise you will perforate the uterus. But usually it is not recommended. You can accurate the uterine cavity, but it is not usually recommended because the uterus is so soft that you can easily perforate the uterine wall. So some physicians or some institutions recommend that some gynecologists recommend the evacuation. Evacuation. Second evacuation after 1 week to ensure that this is completed. This is not like to increase. If the patient is still having bleeding, then we can do a second evacuation. The thicker utensils, which are due to the excessive beta HCG, they are usually bilateral, and the size is just maybe 10 centimeters sometimes. They are hormone dependent, it is okay. Once you have done the evacuation of the mouth, they do not need any surgery, so they are managed easily. These are the bilateral thecal utensils. This is uterus. This is one of them. This is the other. This one so these are the utensils which should not be touched. Left as such. Hysterectomy needed for evacuation of a large bone tumor must be facilitated. but this is obsolete now. Now it is not registered. Hysterectomy should be considered in women if she has completed her family, she is more than 40 years of age, and you have and the patient is high risk for getting carcinoma, then we can do straight away hysterectomy. So hysterectomy is no more. First, you have evacuated the mole, you have evacuated the uterine cavity. You have to follow the patient. Follow the patient with signs and symptoms with beta histology. So it is done. Usually it becomes normal in 8 to 12 months after operation. So it is done weekly till becomes negative for 3 successive weeks. Then it is repeated after every month till 1 year. And pregnancy is allowed if the test remains negative for 1 year. So she should practice contraception for 1 year in case of pregnancy. Persistently high level but rising level of HCG after this appearance means developing of carcinoma on your pregnancy. You are following a patient. Her beta HCG became normal and she had negative reports on her follow-up. Suddenly there is rise in beta HCG. So there are two reasons. Either she has become pregnant or there is development of a carcinoma. So beta HCG is undetectable 4 months after evacuation. So this is the normal time limit in which this beta HCG becomes normal. That is 4 months. So during the period of follow-up, the patient is asked to avoid pregnancy by using contraception. Uh, the choice of contraception is the barrier method. We cannot give OCPs because it will interfere with the arbiter SH interpretation. We cannot give IUCD because it will cause irregular bleeding, so we will not know whether it is due to the molar, post-molar tissue, post-evacuation molar tissue, which is leading to the bleeding, or whether it is due to IUCD. So uh, the choice of contraceptive is barrier method till the beta becomes negative. Then we can switch over to OCPs. This is IUCD. It is not inserted in a molar pregnancy of irregular. Now, invasive mode or chorioadenoma destruens. So this is invasive mole. It is a trophoblastic tumor with penetration of the myometrium by the chorionic villi. So in this chorionic villi they invade the myometrium. It is non-metastatic. This condition is non-metastatic. It is only invasion of the myometrium. It is locally malignant and it may lead to perforation of the uterus. So this is the uterine wall which is invaded by the chorionic villi. This is the mutation which is giving characteristics of strong appearance. So this invasive mole shows increased vascularity. So these blood flow is seen here in case of invasive mole because it is invading the myometrium. This again shows myometrium invasion. This is uterine cavity with no strong appearance, and this is the invasion of the myometrium. You can see the blood flow. Early features suggesting persistent gestational trophoblastic aplasia or post-molar syndrome. So, if a persistent molar disease, what are the features? She may have recurrent or persistent genital bleeding or subinvolution. The uterus is not reducing in size. There is amenorrhea. There is persistence of ovarian enlargement. The ovaries, they are continuously enlarged, they are not reduced in the size. No malignancy in the endometrial biopsy. It is started if persistent or malignant disease develops. Chemotherapy, otherwise not. The level of serum HCG doubles in 2 weeks after exclusion of pregnancy, or it plateaus. So these are the indications of starting chemotherapy. If there is a new persistent or malignant disease, or the beta HCG starts doubling, or it is plateauing, it is not decreasing for a period of 3 weeks. The test for the hormone becomes positive after being negative. HCG it was zero, then it starts rising again. So it is an indication of chemotherapy, or if metastasis appears. So these are the indications of starting chemotherapy uh, in the postmortem patient. Now, what is choriocarcinoma? It is a metastatic trophoblastic disease. It is a malignant form of gestational trophoblastic disease developed from a hydatiform mole from placental trophoblastic cells associated with a healthy fetus, or in abortion or an ectopic pregnancy. So they may develop not only from a complete mole but from a placental trophoblastic cells associated with healthy fetus after a normal delivery, or an abortion or an ectopic pregnancy. So choliocarcinoma is invasive. Locally, it is metastatic, lacks chorionic histopathology. It differentiates from invasive mole to due to the lack of chorionic villi. In invasive mole, there are chorionic villi, but in choriocarcinoma, there are no chorionic villi. Signs symptoms are same: bleeding, infection, mass of abdomen or vaginal mass, uh, symptoms, ordinary symptoms, symptoms from other sites of metastasis. Spread is usually direct, and hematogenous spread is mostly to lungs in about 80% of cases, to vagina in 30%, to brain in 10%, and liver in 10%. So it may spread directly or through blood. This is how you will classify choreography. This is fecal classification. There are four stages. Stage 1, which is confined to the stage 2, metastasis to pelvis and the vagina, local metastasis. Stage 3, to metastasis to lungs. And in stage 4, metastasis to other organs, including brain. But this is stage 1, locally invasive to the vagina. This is stage 2. It is to the pelvis. And this is stage 3 to the lungs, and stage 4 to the brain. How to diagnose poliocarcinoma? Usually with the symptoms, patient present with signs and local examination and investigations. So the main symptoms which I have needed or persistent irregular vaginal bleeding. So if a patient has vaginal delivery, abortion, or evacuation of a vesicular mole, or a shared ectopic pregnancy, if she is continuously bleeding uh, um, for months, but rarely after 2 years. So it is the main symptom. So you must have a suspicion of choriocarcinoma. Vaginal discharge. If infection due to ulceration and infection of the growth will lead to vaginal discharge. Amenorrhea may be present due to the continuous HCG production. She may have acute abdominal pain due to the irritating hemorrhage as a result of perforation of the uterine wall. Further growth, abdominal or vaginal swelling may develop. Symptoms of metastasis, as if lung metastasis, she may develop dyspnea, hemoptysis, jaundice, if lung metastasis, and neurological symptoms are related to the first manifestation of the tumor. Regarding signs of choriocarcinoma, patient may be anemic. There may be fever due to infection and necrosis. The uterus may be normal size or enlarged and soft. So uterus may be of normal size, but it may be enlarged with soft in consistency. The ovaries may be enlarged and cystic. Metastatic nodules may be present in the vulva and vagina. So, what were the signs? Signs were she may have hemorrhage, bleeding. She may have pain. She may have um, mass abdomen, and if the tumors metastasis to the lung opening, then we will have manifestations of the metastasis. And regarding signs, the patient will be anemic, dejected. She may have fever due to infection and necrosis. The uterus may be of the same normal size or enlarged with soft consistency, and the ovaries they may be enlarged and twisted. Metastatic nodules may be present in the vulva. So there are certain investigations which should be done with HCG. Biopsy of the mass, if it is a vaginal mass, then we have to take the biopsy. Imaging techniques include X-ray test for pulmonary metastasis and ultrasonography and CT scan for distinct metastasis. Blood studies include CBC, especially red blood counts, renal function test, liver function test, and blood. So these are the investigations. The main investigations which I said ultrasound, X-ray chest, CT scan, and blood studies include BBC, RFTs, LFTs, and blood. Because you may need blood, so she should know her blood. This is the ultrasound image, Doppler image of choreography. The image was provided and it has generated uterine wall. So whenever there is a patient with carcinoma, we have to score the patient in order to treat her. So scoring system depends on various factors, unilateral, bilateral, vertically, size of the cell, and spread. So according to these prognosis scoring factors, it is scored in low, not great, and high risk. Low risk is the score is 4, 5 to 7 is moderate risk scoring, and high risk is 4 is not any. The treatment of carcinoma, the treatment of choice is chemotherapy. It may be single agent or multiple agent chemotherapy agents may be used. Or surgically, hysterectomy may be indicated in the whole condition. So mainstay is the chemotherapy, but sometimes you may perform hysterectomy in the following conditions because few salvage if this uterine perforation if this torsion fecal uterus or persistent localized metastasis so these are the indications for surgical treatment. Chemotherapy is started if the patient is low risk, for then a single cytotoxic agent, is given. It could be either methotrexate or echinocandin. In high risk group scoring, more than 8, the multiple cytotoxic drugs they are used. So chemotherapy is single agent or multiple agent in the scoring condition. Thank you. So this was all about gestation trophoblastic disease. So we can revise What is what is the characteristics of mole? There is hyperplasia of plastic tissue. There is hydrotic swelling, hydrotic degeneration of the chorionic villi, and there will be, in case of complete mole, there will be no fetus, while in partial mole, you can find it. So, how we will diagnose? If a patient has molar pregnancy, so how we can diagnose? So, we can diagnose with the help of patient will present with excessive vomiting, and she may have the size of the uterus more than the gestational age, and the uterus is too inconsistent. And when we do beta HCG or ultrasound or beta HCG, it will be very high. Usually it is more than 1 million. Usually it is more than 100,000 international units. And when we do ultrasound in ultrasonography, we can see characteristic snowstorm appearance. There will be snowstorm appearance characteristic. So these are the investigations. And these molar pregnancies treatment is suction evacuation, which is the gold standard. We have to treat with suction evacuation. So what we do, we introduced a suction current attached to the suction machine and start evacuating the uterine cavity. These grape-like vesicles, they will start flowing out, and ultimately the size of the uterus will decrease. So follow-up is very important in case of molar pregnancy. Regarding follow-up, we are doing follow-up with a patient in a complete mode for 1 year and in partial mode for 6 months. We are doing follow-up with the symptomatology with beta HCG. Usually, the beta HCG is done weekly, then it becomes negative. After 3 negative, we will continue doing beta HCG monthly till 1 year. And during this period of follow-up, the patient is always pregnant. If she gets pregnant, then it will interfere our interpretation of the VTCG. We do not know whether this rise in VTCG is due to pregnancy or due to the molar tissue. So that's why she's advised to avoid pregnancy, and contraceptive use advised is usually very rapid contraception. No OCPs, no IUCTs, because they will interfere with the interpretation. If with IUCT, they will be irregular bleeding and we will not know whether it is due to the molar tissue or due to the IUCT. And OCPs, they will also interfere with HCG readings. So once it becomes negative, then you can start OCPs. Otherwise, you will achieve continuous contraception. So the other trophoblastic disease, gestational trophoblastic disease, is the invasive mole, which is not interested. And the third one is choriocarcinoma, which is a metastatic disease. And how we can differentiate between choriocarcinoma and invasive mole is on the basis of histopathology, because choriocarcinoma does not have polyp. There are no polyps. So that's why this feature is diagnostic of choriocarcinoma. Then investigations are in progress. And the treatment of this choriocarcinoma is chemotherapy ideally. Sometimes we can do hysterectomy if the patient uh, has diffuse hemorrhage, or she has completed her family, or there is perforation of the uterine wall. Then we can directly measure hysterectomy. Even after that, we have to do follow with the HCG, because it may metastasize to lungs and brain, and persistent tissue may be there, which will be possibility in HCG. So follow continues even after surgery. The gold standard is chemotherapy. So chemotherapy with maybe with single agent. If this patient is low risk, that the score is less than 4, then we can give a single agent that is 100%. And if she has high risk, the score is more than 8, then multiple drugs are started. So this is all about gestational trophoblastic.